Thank you all. Can everybody hear me? I have the portable mic on. Is that okay? Good. First, let me thank the PAINWeek people, because this is my third year, and Deborah Weiner specifically, for giving me the opportunity to come and speak to a group such as this and try and teach and educate you about complex regional pain syndrome, or reflex sympathetic dystrophy, as you will hear me call it probably all day, because I am old enough that that's what it used to be called, and I will probably call it that today. I'm delighted to have a crowd this size. I thank you all for coming, and I want to get into not the pathophysiology of this disease and not what goes on in the brain and the nervous system, but rather the practical applications as we see it in the real world. And what I hope to do in the first hour of this discussion is talk about that. The second hour, we're going to talk mostly about a specific type of diagnostic tool, a specific type of therapeutic intervention. And we were then going to do case studies, and I'm going to kind of do sort of case studies. I decided that sitting and listening to a case study from start to finish can tend to be a little bit boring. So we're going to really talk about atypical presentations of people that I have actually seen in the almost 800 people that I have seen. So that's what that says. In 1998, I gave my first lecture on reflex sympathetic dystrophy, and as a child, I stood up there in front of a group of people, and the first three words that came out of my mouth were, "I don't know." And I looked at this group of people, many of whom were RSD patients, and they looked at me, and I'm sure they thought, if he doesn't know, what's he doing up there on that side of the stage? And there were a lot of things that I did not know in 1998. And now, 12 years later, there's still a lot of things that I don't know. And you will hear me say in the course of the next hour or two, I don't know a lot of times, because I truly don't know, and I'm trying to find out. Interestingly enough, along my journey in the 12 years, I ran across a book and subsequently met a wonderful author by the name of Neil Donald Walsh, who wrote Conversations with God, if any of you are familiar with that. And in this, he talks about people who don't know. And I'm going to borrow, if you will, from him just a little bit before I begin talking about reflex sympathetic dystrophy. He talks about people who don't know, but they don't know that they don't know. And he calls them the innocents. He talks about people who don't know, but they know that they don't know. And he calls them willing and suggests that you teach them. And they're the people that we're trying to reach out to. And then there's a group that he calls, they don't know, but they think that they know. And he calls them dangerous. And I call them referring doctors. Because the people who don't know but think that they know are responsible for keeping me busy. And quite frankly, the less people that I meet who don't know but think that they know, the happier I am. I want the group who don't know but are willing to learn. There are other groups, and there's one group that says they know, but they don't know that they know, and they're asleep. And then there's those who don't know but suddenly remember that they do know. He says embrace them. And then there's a group that says they know, but they pretend that they don't know, and he calls them actors and says to enjoy them. And then the final group is those who know, and they know that they know. And there's about 4 of them in the world. The rest of us are in the group called we don't know, and we know that we don't know, but we want to know. And so hopefully at the end of the day, we will all know a little bit more. So I'm not going to read you what you can read yourself, but I want to highlight certain things. This is a chronic disorder. It is an incurable entity. And invariably, I will say to people, you have something that I can't cure, and the face drops, and they look at me, and the tears well up, and I say, wait a minute, stop. I can't cure diabetes. Nobody cries when I tell them they have diabetes. I want to control diabetes. I want to control reflex sympathetic dystrophy. Maybe someday we'll cure it. Maybe someday we'll figure it out. But at this moment in time, this is an incurable entity that needs to be controlled. Now, you will see in the medical literature, get it within the first 6 months and you can cure it. A, you're probably not going to get it within the first 6 months. And B, I have seen people in remission I fortunately have some people in remission, but I'm not sure that they're really cured. The interesting note is the one that says that the RSD Association says that the average person sees 4.8 physicians, and it's probably a number that they've accumulated over the course of years, but I have to tell you that by the time I see most people in my practice, they've seen well more than 4.8 physicians. Now, I am, by trade, a general practitioner, or at least I used to be. My board certification, in fact, is in family practice, and you heard in the introduction that I'm an assistant professor of medicine in neurology, even though I'm not a neurologist, so I don't want to mislead anyone into thinking that I'm a neurologist, because I'm not. Nor am I a pain specialist. I do not have a needle in my back pocket when I walk around the office. What I am is somebody who involves himself in the evaluation and treatment of patients with reflex sympathetic dystrophy every day. And I've got lots of them, 700 or 800 people that I've seen over the past 12 years. And they come from all over the country, and we sit down and we try and give them a plan, and we try and counsel them. And believe me when I tell you, the first most important thing to do is to take somebody who walked in your office from one of those I don't know, but I don't know that I don't know docs, and tell them that you do know what's wrong with them, because 50% of their problem is gone right then and there. People who don't know what's wrong with them do poorly. People who know what's wrong with them, even if it's an incurable entity, will work very hard to make themselves better in most instances. So knowing and being able to tell someone that you know gives them a step in the right direction. So leftover from 12 years ago. That wonderful word at the back, as I'm sure you realize, says work backwards. And any doctor who doesn't admit to the fact that he or she, or any clinician of any type, works backwards, you know, the term rule out is the medical term for work backwards. But we look at people and we say, I'm not really sure what's wrong with this person, so let's try and figure out what isn't wrong with the person, which unfortunately is the way that RSD gets diagnosed a lot of times. In point of fact, you can actually come forward. Sometimes you see people who walk in and they've got the clubbed hand that's purple and the nails don't grow and the hair is, and all the things that you read about in the book. I see maybe 1 in 100 that way, because it really isn't the way that it presents. It reminds me of my medical school days when they told me that the typical gallbladder patient is the fat, fertile 40 female. 34 years later in practice, I've seen 2 gallbladder patients that fit that criteria. So you really have to look in a broader scope and see what they're talking about when you talk about reflex sympathetic dystrophy. I tell the patients a sensory sympathetic dysfunction. It's very easy to explain the difference to people between people to the I don't know category. But I can tell you that they don't. And so you get this list that you see.
Which would be nice if you see it very often. The RSD Association will tell you that you really only need one of these to make the diagnosis of RSD. The lawyers, depending upon which side of the fence the lawyers are sitting, will tell you that you need all of them. I will tell you that you make a diagnosis of reflex sympathetic dystrophy based upon history, physical examination, and mechanism of injury when in fact there was an injury. People will tell you what's wrong with them if you ask. And sometimes it's just a matter of asking the right questions. All right, let's get this out of the way. Traditionally, they called it reflex sympathetic dystrophy. The term causalgia came from the Civil War that you see 3 lines from the bottom. The Committee on Nomenclature Committee, or whatever they're called, decided that they wanted to call it something else, so they call it CRPS. CRPS1, CRPS2, CRPS-NOS. To me, it's reflex sympathetic dystrophy, with or without a nerve injury, and I explain it to people in that fashion, but it is what it is. I wrote a note one time because a doctor had written this whole long article in the American Family Physician saying, how can you call this reflex sympathetic dystrophy? It's not reflexive, it's not purely sympathetic, and it's not dystrophy. And so I wrote back, and in the thing I wrote this thing that they published saying that my position was different than his.
And they deleted the last sentence, which was as follows. William Shakespeare said a rose by any other name would smell as sweet. George Carlin said, how can we drive on a parkway and park in a driveway? So what difference does it make what you call it? It is what it is. And so you get allodynia and hyperalgesia and hyperesthesia. And the last one, to me, the pain disproportionate to the inciting event, is really a hallmark of this disease. People will come in and tell you that the pain is burning. Don't guide them. Because if you say, is it burning? Then they're going to say, well, yeah, now that you mention it, it is. I ask people, what kind of pain do you have? I get blank stares. I said pain has a nature. It's sharp, it's dull, it's pressure, it's burning, and I throw that word somewhere in the middle, and I let them pick and choose from what they want to do there. But the pain disproportionate to the inciting event really is the hallmark where non-RSD physicians come to the realization that they're dealing with something that isn't really within their domain. Because they're coming in and maybe they had a knee injury and the surgeon fixed the knee and the x-rays are fine and the MRI is fine, and this person says, but my knee hurts. I mean, it hurts worse than it hurt before you fixed it, which of course no orthopedic surgeon ever wants to hear. And the next question really should be, but does it hurt different? Because it will hurt different. Meniscus pain and RSD pain are different pains, so we get back to asking the right questions. But pain disproportionate is really an important criteria when you're evaluating a patient with reflex sympathetic dystrophy. And so you have symptoms of burning pain and skin sensitivity to the degrees of hyperalgesia and allodynia, and the skin sensitivity to cold or hot. And it is not cold all the time or hot all the time. People vary. It is just a variation from the norm. Somebody could come in and say the cold bothers them. Some people come in and say the hot bothers them. Really, there's no established norm such as you can read someplace. It's nice when we have it, but we don't have it. Abnormal skin color changes, abnormal skin temperature is almost always present, but you got to measure it. The human hand is really not capable of detecting subtle variations in temperature. So you have two choices. You can go to thermal imaging, which we'll talk about later. And I went to Radio Shack, and for $49.95, you can buy this thing that looks like a little gray egg that measures temperature by just pointing the thing at somebody. And I use it as a screening tool because it really is relatively accurate for point measurements. You can point it at the wrist and then the other wrist, and it gives you degrees in centigrade and in Fahrenheit. And it really gives you an idea within tenths of a degree. It's just kind of a nice way preliminarily. And besides, people get a kick out of it because you tell them they can go buy one for $49.99 and do it themselves at home. So they think that's kind of cool. You have abnormal sweating, abnormal swelling, weakness, tremor. The bottom one, abnormal hair or nail growth. It doesn't happen as often as they would like you to believe. I have some patients who have no other symptoms but dystonia. Nothing but dystonia. And they're a mess, and they don't function. They don't have any of the other things that you see and hear and read about. And then the RSD Association put this one in. No other diagnosis better explains the symptoms. So we go back a few slides to the work backwards, and we have now eliminated A, B, C, D, E, and F. And we're left with G, which is where we should have been in the first place, but we managed to get there anyhow by going backwards. I think this is the first thing. I think this should be the first criteria when you look at somebody, because we all do this mental calculation. This person has X, Y, and Z, and in your mind you're doing all these things, and you're saying, well, do they have this, do they have that, and in your own mind you're doing all those rule-outs, and before you know it, you're kind of going, so there it is. People will tell me, almost always doctors, RSD does not spread. There's only one paper. I have some copies of it. It was written by Dr. Schwartzman, who has written more papers than anybody in the world on reflex sympathetic dystrophy. And he wrote it in a journal called Pain in January of 2001, if you want to go look it up. And really what it talks about is the spread of reflex sympathetic dystrophy. And in the paper, he says that it spreads horizontally and vertically 95% of the time and diagonally 5% of the time, meaning left arm to left leg or left arm to right arm 95% of the time. I will tell you that probably 75 or 80% of people that I see have spread the disease. And invariably, when it goes to another limb, it's worse in the second limb than it was in the first. Now, whether that's an anatomic mechanism, a physiologic abnormality, or because they just got used to the first limb, and so the second limb seems much worse by comparison, I can't tell you. But I can tell you that the second limb almost always is worse than the first. This, of course, argues in favor of it being a central mechanism, which we all know that it is, because it's not a peripheral nerve problem, and it's certainly not a carpal tunnel syndrome type problem. And so it does spread, and you should expect to see it spread. And I get people that come in the office and they say to me, well, my left arm is just like my left leg, but Dr. So-and-so said it can't be the same thing because RSD doesn't spread. And I walk over and I slam my head against the wall a couple of times, and I come back and I talk to the people again. And sometimes I pull out the article and show it to them. Now, what I would like to do is talk to you about what I see that you won't see in the books. People come in and they say, I have migraine. Next to arthritis, I think is probably the second most overused, inappropriate word in medicine. People tell you they have arthritis, and everybody has arthritis. And probably a lot of them do, but it's not applicable in the context in which we get it. But people come in and say, I have a migraine, so I ask them to describe a migraine. Now, we're all familiar with the classical migraine symptomatology. And this is not a migraine headache. It is almost always a greater occipital nerve headache. And if you go behind them and you take and you press on their greater occipital nerves, the next thing you do is you peel them off the ceiling. Because if you press on someone's greater occipital nerves that has an RSD-related headache, believe me, they will fly off the table. Okay? You might not want to do this on the first visit because it doesn't really build a lot of confidence with the patients, but it is a greater occipital nerve headache. And if you block the greater occipital nerves, the headache goes away. I mean, it goes away instantly. And use your treatment of choice for blocking the greater occipital nerves, although I have to tell you that, as we all do, we get detailed by a number of people, and I had a company that makes homeopathic remedy come in and say, try the homeopathic remedy, and I thought, okay. So I took vitamin B12 and a homeopathic remedy, and I put it in a syringe, and I picked the two most difficult women that I could possibly think of in my practice that had RSD-related occipital nerve headaches. One is a lawyer, and the other one is never happy. And I gave them occipital nerve blocks with homeopathic remedies, and both of them had complete resolution of their headaches. And I said, all right, well, learn something new every day. And so we come back to my famous 3 words, I don't know why that works, but it does. Works better than conventional treatment. I'm getting 6-8 months on an occipital nerve block, and I'm not an anesthesia person. I do very limited injections, but this is relatively easy to do, so it's just something to think of. Sinus headaches are very distinct. Neuralgias from trigeminal nerves, which happen a lot in brachial plexus injuries, which is the #1 cause of reflex sympathetic dystrophy that I see, are easily identified. That's not the headaches these people complain about. Photophobia. When people walk in, I ask them, does the sunlight bother you, the bright lights in the room? Of course, if they walk in with sunglasses on in the middle of the evening, it's kind of a dead giveaway. But a lot of people will come in and you look at them and you say, does the sunlight bother you? And they look at their significant others with them. It's like you're Karnak the Magnificent. You're reading minds. And I explain to them that you do enough of these cases and you recognize that these are the things that happen. Light bothers people. Did it used to bother you? No, not until I got hurt in the accident. Same thing with noise and the bass on a stereo. If they've got kids that are cranking up the bass, they're just horrible. They're walking around with earplugs in, and I mean, it's just a terrible, terrible thing, which is where the vibratory comes from. You can't vibrate. And an interesting thing happened yesterday. I was talking to the folks across the hall that make Fentura, and I explained to them that Fentura, for those of you who know, the fentanyl is something that goes up into the mouth, and it dissolves. It effervesces like Alka-Seltzer does. Anybody that has a brachial plexus reflex sympathetic dystrophy with extension into the face can't use Fentura because the effervescence drives them crazy. And I tell the reps this, and they all look at me because they've never heard it, but I have people do this. Try the Fentura, and they just come back screaming, how could you give me that product? And if they put Alka-Seltzer up, it would do the same thing. But it's the effervescence and the vibration and just that movement against the nerve endings in the mouth, which are so sensitive from the reflex sympathetic dystrophy, it goes makes them literally crazy. Hoarseness, you talk to people, do you get hoarse from time to time, but you're not really sick? You get up in the morning and you think you're losing your voice, and an hour later it's back? Yeah. I just thought that was my sinuses. Well, were your sinuses clogged? No. Okay? That's a branchial, not brachial, branchial plexus irritation from the reflex sympathetic dystrophy. There's one paper from back in the 80s that describes that, but it's a very common finding. You're not going to find that stuff in the books and the literature. Chest pain, palpatory chest pain, reproducible non-cardiac chest pain, especially over the brachial plexus points. Cardiac arrhythmias, tachycardia in young people, especially 18, 19, 20-year-old RSD patients, tach away at 140 or 150. Bradycardia, women 40 to 60. I have 3 patients with pacemakers. None of them have heart disease. All 3 of them have had cardiac catheterizations. Their arteries are fine, their chambers are fine, their valves are fine, and they run about 28 or 30 rhythm before we put the pacemakers in, because the sympathetics are shutting down the rhythm, and these people are walking around bradycardic and they're falling down and they're passing out, and you put the pacemaker in it and they're fine. This to me is the least understood of all of them, gastrointestinal. I have 15–20% of the patients that have GI side symptoms of reflex sympathetic. There is not one single article in the world literature about gastrointestinal manifestations of reflex sympathetic dystrophy. And all of the stuff that you see there, especially the nausea and vomiting, I have a woman who was vomiting to the point that she literally had lost 55 pounds, 30 of which she probably needed to lose, but 55 pounds, and was so sick that they tried everything in the world for her. Now, the treatment that seems to be best when you can't stop the nausea and vomiting by conventional means is to have a gastroenterologist do an upper endoscopy and use Botox and put it in the pyloric sphincter. And that seems to work very, very well to relax it, stop the nausea, stop the vomiting. I've had 2 people that didn't work, and they wound up in an operating room for fundal plications because they couldn't stop the vomiting. And every diagnostic test is normal, save for one, which is the gastric emptying study. These gastric emptying studies are incredibly abnormal. They're 2, 3, 4 times. You get calls from the radiologist, never seen one this slow. And they're just not emptying. And so they have all this food that's sitting in their stomach and it's rotting, and they get sick and they throw it back up. So when you see somebody with a pain syndrome with nausea and vomiting, it has to be part of your differential diagnosis that it's an RSD-related gastrointestinal manifestation. That last one down there, pseudopancreatitis, is a term that I made up. I made it up because I've seen about 10 or 12 people who have elevated amylases and lipases, and they don't have pancreatitis, and they don't drink, and they don't take recreational drugs, and they haven't had any blunt trauma to the pancreas. Now, I'm not a gastroenterologist. I've talked to them, and the number 1 cause, of course, is alcoholism, number 2, blunt trauma, and there are other causes. But these people go into the hospital, they're sick, they're throwing up, sometimes they're to the point of they're throwing up blood, and when you do the blood work, they come back with elevated amylases 3–4 times normal and very slight elevation of the lipase. And when you quiet them down with conventional treatment for the nausea and the vomiting, all the numbers go back to normal. I didn't know what to call it, so I took the liberty of making up a term. But if you have people and you see these numbers, of course you still need to be sure that they're not closet drinkers. But if they're not, this is something that occurs, and it occurs with frequency. Genitourinary symptoms, neurogenic bladders, the one that's down the bottom, is clearly the most common. I have people tell me that they went to the doctor and the doctor told them they had interstitial cystitis. No, they have neurogenic bladders from their reflex sympathetic dystrophy. As you can tell, I make a lot of friends in the medical community. I call the gastroenterologist, I call the urologist, and I'm going, listen, when you do all the things that you're doing, if they don't work, will you call me? And we'll talk about these things. So these are just things that when you see as many people as I've seen throughout the last 12 years, you start to develop it. 1 is anecdotal. 2, you begin to think about it. 30, you have to start paying attention to it. And so you scour the literature, and it doesn't exist. And so then you get people saying, well, why don't you write a paper someday? Immune system compromise. I have a lady who today, and I just got off the phone with my office, is in intensive care at home with an unknown infection from a reflex sympathetic dystrophy and a bradycardia and a pacemaker and all this kind of stuff. And she has no immune system. I mean, her immune system is just horrible. And so she's got some infection, and she's now 9 days in intensive care with some kind of super infection that the ID people can't figure out. And I'm not going to tell you that I can either, except that I'm trying to explain to them they've got to somehow figure out something in some fashion to work on her immune system, because otherwise this lady is going to turn out very poorly. The immune system shuts down. Fortunately, it doesn't do it in everybody, but when it does, it crashes. It doesn't go slowly. Gynecologically, you have all the symptoms that you see there. Secondary amenorrhea, of course, brings about a lot of pregnancy tests. The irregular menstrual period, very common. And so when you get through this whole litany of things that I've just showed you, and now you're sitting and you're talking to a patient who comes into the office and has a pain syndrome, you're really asking a whole bunch of questions that nobody's ever asked them. Because when the person goes to the orthopedic surgeon or the neurological surgeon, or even most neurologists, family physicians, podiatrists, chiropractors, whatever it happens to be, they're asking the fundamental questions. Tell me about your pain, which is all well and good, but when you start to accumulate more data, which is what we're doing here today, you start to realize that all these things play in to the pain syndrome. Knowing this, and some of the people in the area will now say they have an unknown pain syndrome. This is the newest one that I've heard. Well, okay, that's fine, but it's your job, if you're calling it unknown pain syndrome, to tell me why it's unknown and what it is. I mean, that's what we're supposed to be doing. We're supposed to be making diagnoses. And if it's an unknown pain syndrome, but it fits the criteria that I've established here, in my mind, it's no longer unknown. I would much rather have them say, I don't know. So we talk about diagnostic testing, and diagnostic testing tends to be sometimes of exclusion. X-rays, I'm not going to teach anybody anything except that I want to talk to you about triple-phase bone scans. Triple-phase bone scans were once thought to be the gold standard of diagnosis for reflex sympathetic dystrophy. Statistically, somewhere, depending upon where you read, somewhere between 20 and 40% of triple-phase bone scans will show positive in reflex sympathetic dystrophy. I've probably seen 100 patients with triple-phase bone scans, 4 of which showed up positive for reflex sympathetic dystrophy. 3 of the 4, I sent a request saying, would you please look at this and tell me if you think the patient has reflex sympathetic dystrophy? And the 4th one, the patient saw the abnormality and the radiologist missed it. So I don't do triple-phase bone scans at all for 2 reasons. Number 1, I don't like sticking needles in people with reflex sympathetic dystrophy, and I don't like giving them radiation that's unnecessary with little likelihood that it's going to have a positive yield. And 2, I don't like putting a bullet in the insurance industry's gun, which is what I'm doing if the test comes back negative, because they will invariably say the test was negative, therefore the patient doesn't have reflex sympathetic dystrophy. And then I have to write a 3-page letter explaining why they're misinformed. So I don't do them. And I don't think they're worth doing. Discograms and myelograms and arthrograms, which are not very pleasant things to have done, as you all know, are really done to exclude other entities and to look for pain generators. Electrodiagnostic testing, with apologies to anyone in the room who may do EMGs, I think it's barbaric. It is a motor nerve study. It does not give you any information about the sensory nerves, or very little at best. And if you really want to make yourself some money, get a patient with a brachial plexus reflex sympathetic dystrophy who's going to have an EMG and bet them any amount of money that the electrodiagnostician will send you back a report telling you that they have carpal tunnel syndrome, which they don't. Okay? They have a brachial plexus abnormality. They do not have carpal tunnel syndrome, and I get it time after time after time. So I basically try and keep people from having this if I suspect that they have it, because you can make a diagnosis of carpal tunnel syndrome fairly easily clinically. And by the way, there, in my area, which is New Jersey, there are surgeons operating on patients for carpal tunnel syndrome based upon EMGs, and now without EMGs based upon clinical symptomatology. And so they become referring people because they're fixing the carpal tunnel syndrome that people don't have, and they're leaving them with a wicked brachial plexus reflex sympathetic dystrophy. For those of you who don't know what the last one is, QST and ANST, quantitative sensory testing is a vibratory and temperature measurement that's done. There are very few of these machines anywhere around, and as such, it works, by the way. It works very well if you can find a machine that does it, but it's not commonplace to be able to find such a piece of apparatus. And so I'm going to glance over thermography and spend more time in the second hour talking about it. I am as big a proponent of thermal imaging as you will ever meet. I believe it is the best, if not the only diagnostic test to determine if a person has reflex sympathetic dystrophy. It is totally non-invasive. It is just a wonderful, wonderful tool because you can stand someone in front of a camera and know that they have reflex sympathetic dystrophy. And I'm working on finalizing a paper about predictive value. I told you earlier that reflex sympathetic dystrophy spreads. I now have 12 cases of people who had one limb reflex sympathetic dystrophy, thermographic evidence of a second limb involvement, and all 12 of them migrated into the limb that we knew they were going to migrate into before they began to have symptoms. Now, the real question is, what good does that do you? And there are two answers to that question. There's the world I live in question and the real world. The world I live in tells me that we should take those people and block them before they get symptoms. Shut down and block the sympathetic nerve to the area before they get symptoms, and maybe set up a roadblock before it ever becomes problematic. I unfortunately do not live in the world that insurance companies live in. So they're not going to let that happen. But at least when they begin to develop symptoms, at the very, very earliest and first sign of a symptom, you can get them and go right into doing what you need to do to that limb to prevent it from flourishing and becoming as problematic as it will become if these people are being seen by someone who says, nope, reflex sympathetic dystrophy doesn't spread, ergo it can't be that. So the predictive value of this diagnostic test, to me, is limitless, not fair, is limited by the insurance industry and money, but limitless if you live the way I do. So what are we trying to do? Well, we're trying to get people functionally restored, get their pain under control, when possible do physical therapy, and they should all be mobilized. No one with reflex sympathetic dystrophy should ever be allowed to sit. Even if they're in a wheelchair, let them move their hands. I have probably been responsible for the rebirth of silly putty, because I send people out to the dollar stores and say, go buy silly putty and just manipulate it with your hands while you're watching TV. Do something. Mobilize yourself. If you can't do physical therapy, occupational therapy for upper extremity stuff. Find a physical therapist or an occupational therapist who understands the concept of this disease. An occupational therapist who's going to take and stretch somebody's arm up over their head as a part of their treatment when they have a brachial plexus injury is not somebody I want treating my patient. So what I do when I write a prescription, I said, please evaluate and call me. Because by doing it that way, I have not given them an open-ended license to do whatever they want to do. I want to know what they're going to do, so I'm going to find out in my own mind if they know what they're doing. I'm not going to tell a therapist how to be a therapist, not my job. I want to hear what they have to say, and if what they say scares me, then I need to find somebody else to see that patient. Psychological, we could probably do an hour on the psychological ramifications of chronic pain, chronic disease, and reflex sympathetic dystrophy. I put it up here so we do not ignore the psychological ramifications. When a woman, and I say woman because 80% of people that I see with reflex sympathetic dystrophy are women. When a woman walks into my office who was doing well and she's had a flare of reflex sympathetic dystrophy, the first question I ask is, did you have an injury since I last saw you? And the second question I ask is, what's the matter at home? Because if it's the kids or the husband or the family or whatever it is, something is setting that off, and it's not physical. I have a lady right now in my practice, long story short, who was going down the drain extremely fast. I mean, she went from kind of hovering at the reflex sympathetic dystrophy window to down the bottom of the well literally in 2 weeks. And after a great long fight, we got her approved for treatment, and we treated her with the ketamine, which we'll talk about later. And after 2 weeks of ketamine, she was right back to where she was before the flare-up. And then her mother came to live with her. And she had to take care of her mother physically, and she had to take care of her mother's emotional needs, and by her own admission, her mother is a nasty woman. And she is no longer where she was beforehand, but she's now back to where she was when she went into the flare. There have been no physical entities. This woman lived through financial hardship, a teenage daughter, which is a trauma in itself. She has lived through all kinds of things. The only thing that changed was mom came to live with her. And she went plummeting for purely psychological reasons. Okay, diet and lifestyle alteration, unbelievably important. You've got to get people to lose weight if they're too heavy, stop smoking, and you've got to get people to stop talking about my reflex sympathetic dystrophy as if they bought it and took it home with them from the store. Those who say, I have this disease, Okay, but I'm not going to let this disease beat me. I'm going to get up, I'm going to get dressed every day, I'm going to go to work, do much better than those who say, you can't believe how bad my reflex sympathetic dystrophy is today. You've got to turn these people, and if that means having a psychologist involved, then by all means have a psychologist or a psychiatrist involved. Anti-inflammatory diets, we're working right now on putting together the ultimate anti-inflammatory diet. There's actually books on anti-inflammatory diets. The more inflammatory the diet, the more pain people have. This disease is based on inflammatory foundations. Somebody comes in and eats a highly inflammatory diet, they will get worse. Okay? Alternative therapies, I have a wonderful set of thermographic imaging where a patient had nothing but Reiki done. And you see in thermographic objective medical evidence how the thermogram actually got better. Her pain got less and her studies got better simply by Reiki treatment. Manipulation and massage is great if they can tolerate the touch. Acupuncture, some people do very well, again, depending upon how sensitive they are. The last one, yoga and meditation, to get people to calm down. And vitamins and nutraceuticals, in my ever-expanding base of knowledge, intrinsic factor, for those of you who are not familiar, increases the body's ability to absorb vitamin B12. Gamma-linoleic acid, which is not up there, works as an anti-inflammatory in combination with these two, and the combination of B12, intrinsic factor, and gamma-linoleic acid reduces nerve pain, and it does it without side effect. It's a wonderful little combination of things that makes people feel better. Some of the nutraceutical companies will make this in combination, and it works very, very well. And you have to be open-minded to looking at things that work, because the answer doesn't lie in opioid prescriptions. I told you earlier that we do discograms and myelograms for pain generators. It is important to locate and treat. If I've got a patient with a symptomatic disc herniation, symptomatic being the key word, I send them to the operating room and I fix their disc herniation, because I can't fix their reflex sympathetic dystrophy until I fix their primary pain generator. Now, somewhere in the audience there's 10 or 15 people going, but you can't operate on people with reflex sympathetic dystrophy for fear of spreading the disease, which is the common thing that surgeons will tell you. And in point of fact, it is not true. And when we talk in the second hour about ketamine and how we're using ketamine, I will explain to you that using ketamine intraoperatively all but 100% of the time stops the spread of reflex sympathetic dystrophy, allowing you to go in and operate on people and remove the pain generator. Not to mention the fact that you are making people feel better psychologically, because you're taking some of their pain down, and because you're being proactive in your approach to removing that which is causing them pain that you can control. Okay? Similarly, if they're diabetics, get their diabetes under control. Hypertension, pick the disease. You've got to have it under control. You've got to have that which you can control at a steady state in order to work on that which you can't control, but you're trying to control. A great misconception is that pain medicine works for pain. It does. But pain medicine does not work for all types of pain. And so I take the time to sit and talk to people and explain to them that there are at least 4 different pains. There is muscle pain, which every one of us understands, because we've all had muscle pain. When you have muscle pain, take something for muscle pain. Take a muscle relaxant. And I'm talking about now if you're taking a medicine, because sometimes heating pads work, or cold packs, or whatever you happen to be doing. But with the assumption being that we're looking at medication, muscle relaxants for muscle pain, anti-inflammatories for inflammatory pain, analgesics for deep bone pain. You will hear the term deep bone pain coming from RSD people all the time. How would you describe your pain? It's like somebody took a screwdriver and drilled it in the middle of my arm. It's in the bones. That's classic reflex sympathetic dystrophy pain, assuming they don't have a fracture. And burning pain, use the neuroleptics or the anti-epileptics from Neurontin on down. A word of note, you see all these commercials on TV about Lyrica, and I have nothing against Lyrica, but if you're going to give Lyrica to a woman, you better warn her that she's going to gain weight. Because even though the company tells you that they won't, it's not true. I've seen people gain as much as 60 pounds on Lyrica. So be careful of Lyrica if that's your drug of choice, because Lyrica will put weight on women, as will Elavil, but we'll talk about that now. Concurrent medications, antidepressants, I use no Elavil in my practice, amitriptyline. I use none because, number one, it puts weight on women. Show of hands of the women in the audience. If you walked into my office and I say, here's a drug that may control your pain, it's going to make you a little bit sleepy, but the chances are you're going to gain 10 or 15 pounds, how many women would take that drug? Good, okay. So I don't use any of that. Now, that doesn't mean that I don't use Cymbalta or some of the other things that are out there. I don't use them for pain. I use them for depression. But I do not use any of the tricyclics specifically for the indications that they used to use them for, because it gives everybody a dry mouth and it puts weight on people, and there's just no point in that. Anti-anxiety agents, you've really got to be careful, especially the benzos, because if you've got people who are already depressed from chronic pain, the benzos will make them more depressed. Antispasmodics, please don't confuse antispasmodics with muscle relaxants. Please don't think that baclofen and tizanidine or Zanaflex do the same thing as Flexeril, because they don't. Baclofen and tizanidine are for movement disorder things. They are for the people who come in and tell you that when I get in bed at night and I relax, my arms start to go like this and my leg kicks out and does that. This works wonderfully well for that. Makes people happy, and it makes their significant other happier. But that's where they have a place. Calcium channel blockers really don't have much of a place, but people use them. Antihypertensives, of course, are specific. The other side's a little different. Famidronate is a drug that was released in France and never really made it in this country for two reasons. One, it's exceedingly expensive. And two, I don't think anybody's really sure what it does. What it doesn't do is work very well in RSD people, although it's been studied. Lenalidomide is a third-generation thalidomide, so you're limited in women of childbearing age and men with women of childbearing age. It does work. And it does work well if you can afford it. It's, again, very, very expensive. Mexilatine is actually generic lidocaine. Mexilatine in capsule form in a non-cardiac patient paradoxically works fairly well to control RSD-related pain and symptoms and doesn't give anybody side effects. Capsaicin is a topical cream. DMSO has been reformulated, and you no longer smell like garlic for 8 consecutive days. And you don't have to get the stuff from the vet in the strength that they used to use it on horses. Dextromethorphan, of course, is the DM in Robitussin DM, and dextromethorphan, pure dextromethorphan, actually does control pain in some of the milder cases of reflex sympathetic dystrophy. And amantadine, which was originally released for H2 influenza virus and Parkinson's disease, again has a paradoxical effect in some people. It's also a drug that doesn't have any side effects. So it's not a bad one to try if you have somebody on the light end symptom-wise. And then there's ketamine, which is going to be the source of part of the second hour. But ketamine is just simply, to me, and the best of what we have right now. It is not the be-all, end-all, and do-all, but it is the best of what we have right now. Other therapies, sympathetic blockade. If you get somebody early, it's terrific. But sympathetic blockade is not something that in general lasts for any length of time. Again, if you do sympathetic blockade, 80% of people have sympathetically dependent pain, meaning they will respond to sympathetic blockade, 20% do not. So be prepared for somebody to not respond to a sympathetic block and have somebody else tell you, well, the fact that they didn't mean your diagnosis is wrong because of the 20% factor. Brachial plexus blocks are a little more complicated for the anesthesiologist. Hospital-based epidurals are like giving sympathetic blockade over a 5-day time frame. We put an epidural catheter in their back, and we let them lay there for 5 days. And we take them to the point where we analgesize. We get analgesia, not anesthesia. Never was able to figure out that word. The people are able to get up. They're able to walk to the bathroom. Some of them have indwelling catheters because of bladder issues. But it's kind of like a 5-day sympathetic block. And again, on the earlier stages of the disease, it works very, very well, more in the low body than the upper body. Spinal cord stimulators, in deference to the folks across the hall, I do not recommend spinal cord stimulators unless the person has one limb disease. The newer stimulators have leads that will allow you to do more limbs. It's not about how many stimulators or how many leads. Once that disease begins to spread, stimulators just don't work. And again, my opinion, in my practice, somebody comes in with an arm problem, you put a stimulator in, it's great. If somebody comes in with an arm and a leg problem, I just move right on and don't even mention it. Intrathecal pumps, to me, are the treatment of last resort. When you tell somebody you're going to put a pain pump in them, they pretty much have come to the conclusion there's nothing more you can do for them. And now you're just trying to manage the pain. So I try very hard not to mention intrathecal pumps unless I absolutely positively have to. Zinconotide is snail venom or Prialt, which I'm not real excited about it in the exposure that I've had. Some people think it works great. I haven't had much success with it. And surgical and radiofrequency sympathectomies really are something that I stay away from because invariably, in some instances, the nerve will grow back, and in some instances, you make the people worse by trying to make them better. It's too definitive for me. If it doesn't work, you're kind of shot, and you got no place to go. And so I put this up there for two reasons. The reason number one is that I'm a Sherlock Holmes fanatic, and that's what got me into this business. I love a mystery, and to me this is one of the great medical mysteries that exist. I got started doing this because I had people that had an unknown pain syndrome, as it turns out, and the unknown pain syndrome turned out to be reflex sympathetic dystrophy. But my feeling here, much the same as what the RSD Association of America says, that no other entity best suits the constellation of symptoms, is that it's not, I love the claim when you eliminate the impossible. The fact of the matter is that this is not an impossible disease to diagnose. I grant you, as you will see a little later, there are cases that get confusing. You know, it's nice when somebody walks in with the classic symptomatology. It doesn't happen very often. But if you have all of the bullets that I've given you today with symptoms that involve the body, with differential types of pain, with the questions as to how this occurred, when you put this whole together, it's not an impossible diagnosis to make. It's actually a very feasible way to go about it. And the reason that I think so many people have problems are twofold. One, in order to take the kind of history that we're talking about here today, you need time, which we don't have as medical practitioners, or let me rephrase it, we don't take. Because the way that medicine is right now is predicated upon doing things in a hurry because you've got to get volume and the reimbursement and so on and so forth. How I got around that was I don't take the insurance for the people that come in. I ask them to pay me in cash, and I take the time that I need, and I set it up on a day when I don't see any other patients. So I'll spend 90 minutes with somebody in a room because I have 90 minutes because they're paying me for my time. And when you have 90 minutes and you have the medical records to look at, and you see all the things that have been done and all the mistakes that have been made, and you ask all of the questions that you now know that you have to ask, it becomes much easier to make a diagnosis and formulate a treatment plan. The second reason that I think is because we, as clinicians, have dropped the ball on educating about reflex sympathetic dystrophy. I don't think the medical schools do much about it. I think in medical school you get about 2.5 minutes of reflex sympathetic dystrophy in a 4-year medical school education. I gave a lecture at a local medical school last year, and before I started I asked how many people in a second-year class had ever heard of reflex sympathetic dystrophy causalgia or complex regional pain syndrome, and I had one hand in an audience of about 125 people. And that's kind of scary and kind of sad, because this is an entity, depending upon who you believe, that there are between 1.5 and 10 million people in this country with this disease. Well, 10 million if you go that way, or even split the difference and go 5.5. 5.5 million people with this disease, we ought to know more about it. We ought to be doing better for it. We ought to be able to we ought to be able to diagnose it, and we ought to be able to find it early, and we ought to be able to treat it. And so what I'm doing here and what I'm doing at home in New Jersey is embarking on a crusade, if you will, to try and educate people, patients and caregivers and medical personnel so that we can understand this. I tell you that anybody, and I'll take questions in a moment, anybody after today that has a question, I'm happy to do it. Anybody that wants a patient to come down and see me, I'm happy to do it. Anybody who wants to know what to do with a patient in their office. Last year I came here and I gave a lecture and I had 6 people call me during the course of the year. My pleasure. Because what happens is if you learn, then somebody in your neighborhood is going to get better and another doctor is going to learn, and so on and so forth. So that's as far as it goes for there, and I will kind of step down here and take questions from in here when I can hear better. Go ahead.
Is there a relationship between the delay of diagnosis and the incidence of spread?
Start again. I didn't get the beginning.
Is there a relationship between the delay of diagnosis and the incidence of the spread?
Not that the question was, is there a relationship between the delay in diagnosis and incidence of spread? Not that has ever been documented. And
I find that by the time that you get to the 4.8 physicians, it has already spread in all most cases. So I don't know where it would have been if they'd have gotten it 6 months or a year into the disease process. And there's only that one article on spread anyhow, and it doesn't talk about the onset of diagnosis in the article. Yes, ma'am. That's the branchial plexus when you get hoarse like that.
Parkinson patients, and so we use amantadine quite a bit. It does sometimes cause this modeling of purple modeling of lower extremities. Is that an issue with the temperature, with the thermal issues, or the coloration in patients with RSD?
I've never seen amantadine. I've probably used amantadine in 100 people. I've never seen it have a single side effect. And I'm wondering if what you're seeing is not the manifestation of the disease, not the manifestation of the drug.
I have a few patients who have an entity called erythromyalgia. Is that pretty much RSD? You know that?
Erythromyalgia is something about which I know very little, and I'm not going to be able to answer the question because I don't talk about things I don't know much about. But I don't know that they're the same entity. Yes.
When you talk about the lesser-known symptoms and you are looking at GI and all that kind of stuff, how do you know those are related to the primary disease process? And then how would you treat them differently if you have menstrual irregularities or GI stuff or cardiac arrhythmias, and you're saying these are related to a primary RSD? Then how are you treating them?
Well, the question had to do with secondary symptoms and how do I know that they're related to reflex sympathetic dystrophy. The answer is I don't. Okay? Which is why what I'm doing is working backwards. I'm making sure that the cardiologist says to me, I've run this test, that test, and the next test, and I can't find an anatomic or physiologic reasons for this latent bradycardia. Okay? Knowing that, I can now relate it back to the RSD. If the gastroenterologist can't stop the nausea and vomiting and the CAT scan and the endoscopy and the HIDA scan are normal, then I'm doing it that way. I'm letting the specialty people tell me what it isn't to know what it is. Someone,
How do you find you?
I must tell you that my wife normally comes with me, and before we leave the house, she says, "Don't forget to take business cards." And she's in New Jersey, and the business cards are in New Jersey. So I ran yesterday down, and I made some copies of a business card. But I will have a website by the end of the month. It's very simply drgetson.com. It doesn't get any easier than that. And it will surprise no one to know that the entire website is being built predicated upon Sherlock Holmes. But it will give you contact information and that stuff. The only thing that I ask of people is, number one, that they provide me with medical records before I ever see the patient. I don't charge anyone to review medical records, but I'm not going to bring someone in and take their time, my time, and their money if they don't have a reasonable chance of getting better by what I have to offer. So we make a phone call, we get the people in, and we see them. And then I don't take new patients on to treat them anymore. I take them on really more to advise other folks of this is the best way to go and work with whatever clinical folks they want to work with, because it really gets overwhelming to take people on and treat them. I would much rather do it on a consultant basis. Yes?
With the different spreads, do you see many people who basically have all over RSD?
I see. The question was whether I see people with all over RSD, and the answer is I see a lot of people with what I call full body disease. I get into trouble with those folks that don't believe that there is such an entity as full body disease. But to me, full body disease is multi-limb and internal organ involvement, and yes, I see lots and lots of people like that.
I had somebody come and tell me they had global RSD.
Well, I guess you can call it whatever you want. You can call it global, you can call it full body, but when it starts to go, it just starts to go. Rarely do I see anybody that just has one limb that's affected and nothing else.
Do you ever see this in association with anything besides trauma, like infectious disease, for instance?
The question was whether I see any RSD in non-trauma situations, and the answer is yes, I do. First, you've got to understand that trauma takes many faces. I saw a lady last week that the trauma was that she went to the hospital for endoscopy, and when they put the IV in her hand, they hit the nerve. And so she's got RSD from the trauma of the insertion of the IV, which most people wouldn't really consider trauma, but by strict definition is trauma. Do I see people that have had this from infectious disease reasons? Yes. I've got a couple of people that try as I might, I can't trace back any kind of traumatic event, hard as I've tried, and I tried, okay, and they just get the disease. Which brings me to a point that I guess I should have mentioned, and I will mention it now. And I don't know why I didn't do it before. Maybe I just glossed over it.
Make no mistake about it, there is a genetic predisposition to this disease, I'm sorry. There is a genetic predisposition, absolutely positively guaranteed. You will find nothing in the medical literature. Again, 1 or 2 cases is anecdotal. I'm up now to 16 families with this disease, where more than one member of the family has the disease, and that's no longer anecdotal. What the gene is, what the predisposition is, I do not know. It's a little longer than I don't know. But it absolutely occurs. And I suspect in some of the cases that you're talking about, it may simply be that the gene is there and somebody is just getting fulminating disease from something that set it off, maybe because their immune system was somewhat compromised and shut down, and then something came along to set it off. Yes?
You didn't mention anything about opiates, methadone, anything like that?
I didn't mention, you're right, I didn't mention anything about opiates, and in the second part of this, we'll talk about drugs and treatment and stuff like that. I wanted to try and separate them out, but we'll talk about opiates in just a few minutes.
What is Reiki?
Reiki is Oriental energy medicine. It is done by qualified practitioners. It is an energy technique where the practitioner works on the energy field of the patient without touch. So somebody who cannot handle contact because they're allergenic or hypersensitive to touch will respond to it, and it works very, very well.
I like the name RSD better than CPRS or CRPS. Yeah, I work with a lot of vets. How much do you see it in veterans?
The question was how much do I see it in the veteran population? I'll give you 2 answers. Number 1, I don't see much of it because of the fact that the vets all go to the veterans hospitals. I can tell you that we have reached out to Walter Reed Army Hospital, who for a while was talking about involving us in a study using ketamine for RSD. However, they've decided they're going to do it on their own, which is a little scary to me. But I can tell you that they're actually so acutely aware of RSD in the military that they have teams flying in to the battlefield. They're plugging people in with IVs and giving them ketamine right there on the battlefield when they have major injury. So they're aware of it.
Yeah, I worked with the VA for 2 years, and I do their pain panel, consulting with primary care physicians on managing their pain, but I've not seen one diagnosis of RSD.
Well, the big problem, of course, in diagnosis is that most people in primary care don't diagnose it.
Yeah.
Yeah. I'm concluding that the thermography will be kind of the gold standard for diagnosis.
If I have my way, it will. She said she's concluding thermography would be the gold standard. If I have my way, it will.
But who and where to get it done? And the second, about ketamine, inhale, or the ketamine coma, or other things, I don't know if you're going to...
We're going to talk about both thermography and ketamine in the second part of what we're doing. Yes, sir.
From a psychological perspective, any advice to patients going out on the internet and looking at all the information out there and then sort of getting overwhelmed?
Well, yeah. The question was whether or not, what advice do you give somebody who's going out on the internet and getting overwhelmed? And I start by telling people that a diabetic can control their diabetes with diet, and some diabetics take 4 insulin shots a day. And so we'll make the assumption that you're going to be the former than the latter, because not every RSD patient is the same, and your goal is to be one of those people who can do constructive things. See, I'm originally from Philadelphia, so we grew up in the area where Bobby Clark, with his diabetes, played for the Flyers and played very credible hockey. And so I use that as an explanation to say, you can live a normal life with diabetes. Why can't you live a normal life with this disease? Let's do the things that we have to do, and stop looking at all the stuff that you hear out there, because it's mostly negative. Yeah. I mean, the RSD Association of America's website, which is rsdsa.org, is really kind of the definitive one, and it stays away from a lot of the negativity. Some of the other sites are run by patients, and they tend to be people who are buying into I'm in a wheelchair, 2 years after I got this disease, leaving out whole chunks of the fact that nobody did the right sorts of things along the way. Okay, if I've got all the questions, I'm going to take 5 minutes and stretch your... Did I miss one? Oh, I'm sorry.
The homeopathic remedy that you use, was it specific for that person?
Nope.
Or you use
Nope, I've used it. I've used it a number of times, and it works.
There are a lot of different, do you know what specific was? Because there are a lot of different homeopathics for headaches.
Yeah, I actually used, it comes out of Heal, the Heal company, the homeopathic company called Heal. I used a couple of their products. I'll talk to you about it, separate. Thank you very much. Well, for those of you who stayed, thank you, and let's talk about some other stuff, and we'll do it a little more interactively, if you will. If you have a question along the way, then we'll stop and we'll answer it, because this half's going to be a little bit different. I had a question that was asked of me in between about age, and as I said earlier, this is a predominantly female disease. It's a disease that about 80% of the people that I see are women. My women patients tell me that women get RSD because men couldn't handle it. I'm inclined to agree. And I will tell you that women are much more supportive of their men who get the disease than the men are supportive of the women. And we talked earlier about psychological, and boy, it's nasty to see what happens to families when the non-supportive male spouse gets tired of having to take care of or put up with the female with the disease. In terms of age, most of my female patients run 30 to 50. The youngest patient I ever saw was 11. She's fine, by the way. She has no symptoms. And the oldest was 81, and she died from other things and never really was terribly encumbered by her reflex sympathetic dystrophy. Some of the men that I see do very well, and some of the men that I see do very poorly because they just want to sit down and let somebody take care of them forever. Anyhow, we're going to talk more about diagnosis and treatment in this particular hour, and I would be remiss if I didn't start talking to you about Sherlock Holmes. Somewhere Arthur Conan Doyle is smiling, I suspect. I will read this one to you. Most people, if you describe a train of events to them, will tell you what the result will be. They can put those events together in their minds and argue from them that something will come to pass. There are a few people, however, who, if you told them the result, would be able to evolve from their own inner consciousness what the steps were which led up to that result. This is the power of reasoning backward or analytically. Now, one of the things that we do as diagnosticians is try and reason analytically. And I think that part of the problem that we have with this disease is sometimes we look but we don't see. And to that end, I decided that I wanted to share the story with you, which someone says is true, and you can decide on your own. But I think it makes a point about looking at someone to make a diagnosis. As the story goes, a little Mexican boy coming out of Mexico across the border into Texas approaches the border guards on a bicycle with 2 saddlebags. And in the saddlebags there's sand. And so the Border Patrol says, we know that you're bringing something across the border that's illegal. We're going to find it. And so they take him aside and they go through the bags, and sure enough there's sand. And try as they might, they can't find anything but sand, and so across the border he goes. 1 week later it's repeated, and this time they x-ray the bicycle because they figure maybe there's something in the bicycle. And there's nothing there. The 3rd week they do chemical analysis of the sand and find out that it's sand. The 4th week they strip search him and do all kinds of things, and this goes on for 3 months. At the end of 3 months it stops. And they never did find out what he was smuggling until 6 months pass, and one of the Border Patrol guards is sitting in Juarez, Mexico, in a cantina, and this little boy walks in, and he walks over to the little boy and he says, look, you probably remember me, I'm the guy from the border, and I know that you were smuggling something across the border. But darn, we could never find it. I'm off duty, we're not going to do anything to you. What were you smuggling? And the little boy looks up at him and says, bicycles. So you see, the problem as it exists is that we see things and we know that they're there in front of us, and yet we don't see them. So I'm going to give you some help. We talked about this earlier, and I'm not going to repeat it. Okay? We are going to talk about thermal imaging. Now, let me give you a little history of thermal imaging. Thermal imaging goes back into the 1940s when infrared was used by the United States government. They used to arm planes with thermal imaging cameras to fly over missile silos in the Second World War. Missile silos that were making missiles actively were hot silos, and so they bombed them. Missile silos that weren't actively making missiles were cold silos, and they flew on past. And the government kept this technology to itself until the 1950s, when they released it for medical applications. And then in the 1960s, it really became something that was of greater availability. And in 1982, the Food and Drug Administration of this country said that it was a classified entity and it met the standards for diagnostic testing. Now, as a quick aside, and we're not really talking about that, thermography has fundamentally three uses: neuromuscular, which we're going to talk about today, thyroid and dental applications, and the earliest possible detection of breast cancers. And I could digress into breast cancer, which is not what I want to do, but I want to mention that thermography, by more than 10 years, predates mammography, and I would venture to guess that while many of you may have heard about thermography, you probably don't know much about thermography. Infrared imaging is based upon the principle that certain things cause heat and certain things cause cold. All of the things that you see on that list cause hyperthermia, or increase heat, and all of these are hypothermic. So we have the ability, if you look 5 down where it says sympathetic stimulation, to be able to measure sympathetic dysfunction in a non-contact, non-barbaric, if you will, means where people can simply stand in front of a camera that emits nothing but absorbs the body's ambient heat, converting it into an image which shows up on a computer laptop screen, which converts into something that we can make an image and we can look at, which you will momentarily. The value of thermography is this: if you do a thermogram in the first 6 months of a patient's reflex sympathetic dystrophy, you will see acute nerve irritation, which again is the 5th one down. After 6 months, you see sympathetic stimulation, which comes up looking cold rather than hot. And so you will see in a moment, and has anyone in this room ever seen a thermographic image? Okay, so a couple of you have. I'm going to show you in a minute how you look at a thermographic image for the first time and recognize that there's something wrong. Now, it would stand to reason that if we have a non-invasive, non-caustic, relatively cost-effective diagnostic test, it would be embraced. That would stand to reason if we lived in any country that wasn't the United States. Because in this country, they're not going to embrace anything that streamlines the diagnosis, because this is not part of mainstream medicine. Why is it not part of mainstream medicine? Because the radiologists, are there any radiologists in here? Oh, good. The radiologists, okay, want a monopoly on reading pictures. And they can't control thermographers because it is not radiologic. So we have a diagnostic test that is non-radiologic, no X-radiation at all, and they can't have it to themselves, so they campaign against it. The president of the American College of Radiology, whose name I won't mention, or the years, so it's not current, this is some 15 or so years ago, was a big proponent of thermal imaging, wrote papers on it, extolling the virtues of this new and wonderful diagnostic technique. And they formed the first American Academy of Thermology, and he expected to become president, and he didn't win the election. So he became the Antichrist, and then started writing articles about how it really doesn't work, which kind of called to question his original articles, but we're not going to go into that. And so I met him one day. We actually were deposing him in a legal case that I was a part of. And I sat down with him. I'd never met him, and I said, "Can I ask you a question?" He said, "What?" I said, "Are you the dumbest human being on the face of the earth?" I make lots of friends, as I said earlier. And he looked at me, and he said, "What do you mean?" And I said, this is before MRIs, I said, "Every thermogram that I do that's abnormal requires a CAT scan or a mammogram or some kind of radiologic. So I'm making you money by doing what are you thinking?" To which his response was to get up and walk out of the room. But it is a physiologic study. Now, as you all know, physiology precedes anatomy by varying time frames. People get sick with pneumonia before the X-ray actually shows X-ray evidence of consolidative pneumonias. And they get better before the X-ray clears up. It's just sort of the easiest diagnosis. And so thermal imaging is out here as a diagnostic tool that makes perfect sense. Okay? So because reflex sympathetic dystrophy is caused by the sympathetic system overreacting, without sufficient parasympathetic tone to balance it, you get excessive vasoconstriction of the blood vessels that can cause cold hands and feet. Anybody treats this disease, people come in and say, "My feet are cold." Or their feet are cold and they say that they're on fire, which is sort of the enigma. But, and because of that, we can take thermal imaging pictures that look like this. And they gave me a laser pointer here somewhere so that I can, or not find the laser pointer. Ah, there it is. Wonderful. Okay. So here's what happens. We take a thermal image of the left leg and the right leg. A patient is facing the camera, and I have a temperature gradient scale over here that goes 8 degrees from start to finish. And I take a picture of one leg, and I take a picture of the other leg. Okay? And if you've never seen a thermal image before, geez, they don't look alike. It's just that simple. They don't look alike. Now, you're looking at this and saying, boy, that really looks terrible. That's the bad leg. And that's the bad leg because if you look over at the scale, the blues are colder than the reds and oranges. And so all these yellows and reds and oranges over here, this is the normal leg. Now, the history that goes with this particular case, which is interesting, is a woman who was involved in an automobile accident, smashed her knee against the dashboard, tore cartilage in her knee, had a medial meniscectomy done, and for about 6 weeks after her medial meniscectomy was fine. And then walked into the office one day and said, my knee hurts again. Well, that doesn't fly with me, so my question is, does your knee hurt the same again, or does your knee hurt different again? He said, no, as you mentioned, it's entirely different. It used to just ache, and then I would do certain things like squat, and it would be real sharp. But now it's more like burning. It's more like on fire. You know, and the bells go off, and the Mormon Tabernacle Choir sings in the background, and stuff like that. And so I take these pictures, and I show her to her, and I say, well, there's something wrong with your knee. So I call the surgeon, and I explain to the surgeon that he needs to get an MRI of the knee, because I need to be sure, in answer to your question earlier, or somebody's question, how do I know it's not anatomic? Okay? So we do an MRI, and the MRI is perfectly fine, and so the surgeon, the orthopedic surgeon's in here? Okay. My son-in-law's an orthopedic surgeon. I've got to be careful. My son-in-law's an orthopedic surgeon. So the orthopedic surgeon says what they do, which is, I did my job. I fixed her knee. And in this particular case, I said, yes, you did. Her knee's fine from an orthopedic perspective. Unfortunately, she's got reflex sympathetic dystrophy in her knee, to which the lawyer says, and this is a great question, did the RSD come from the surgery, or did the RSD come from the accident? And the answer is both. But the surgeon didn't do anything wrong. He did what he was supposed to. He fixed the lady's knee, anatomically. The problem was that when she injured the knee, she didn't only injure the meniscus, she injured the nerves. So he went in and did what had we known she had reflex sympathetic dystrophy, we would have done different things anesthetically, we'll talk about in a minute, anesthetically, to perhaps prevent her from being where she was here. So here's a situation where he did everything right, but it turned out wrong. Now, would it have turned out this way anyhow? Probably. She'd have probably been worse. We had to go get the pain generator. We talked about that in the first hour. But we didn't have to do it the way we did because we weren't smart enough to know that she had RSD, because we figured she hit the knee, the MRI was abnormal, she had the right pain, everything went the way it was supposed to go, but the outcome didn't work. So theoretically, we're back to that world I live in, theoretically, everybody should have a thermogram. Because if I had this, it would have changed the way that I approached her knee surgery. Similarly, this the bad side, left hand, standing this way, okay? This the bad side, again, because the colors are here. And she has 1, 2, 3, 4, 5 digits here, 1, 2.5 here. She actually has 5 on each side. The issue is that the index finger here and the fifth finger here are so cold that they actually drop off the scale of temperature differential, and it's all measured down here. There's a number down here that most of you can't see that says 4.3 degrees, which means that in the confines of the circle, the temperature differential between the two sides is 4.3 centigrade degrees. I don't remember the conversion to Fahrenheit, but it's 4.3 centigrade degrees. Anything more than 1 degree centigrade, either in adjacent body parts or contralateral body parts, is considered thermographically abnormal. There is nothing else that this can be. This cannot be vascular. Why? Good question. Because this part of the arm is relatively symmetrical, and this part of the wrist is relatively symmetrical. It's not till we get here. So in order for this to be vascular, which is the only other possibility, she would have to have some kind of vascular occlusion here, which she clinically does not have. So we're back to how do I know it's from the disease process? Because she's got pulses and she's got the nice things in the temperature-wise when she's not in a flare, and so I've got this going on. Now what makes this particular case interesting is this lady doesn't have any pain in her hand at the time these pictures are taken. This lady has terrible pain in her left knee. Now she has pain in her left hand, but she didn't at the time, okay? And this one here, this is the back, this is the left side of the back and the right side of the back, and you see this little area up here of hot, and this area over here. This is a relatively symmetrical study. And I put this study in for this reason, and I'm going to alienate at least one person in the room right now. This lady came into me with a diagnosis of fibromyalgia. I do not believe that fibromyalgia exists. Let me repeat it in case you didn't hear me. I do not believe that fibromyalgia exists. I have in this bag, for anybody who wants an article, it's the only one that exists, and I have 3 in here. I have one on spread, and I have one on thermography, and one I have about 25 copies, so if anybody wants them afterward, you're welcome to them. But a doctor in Spain, I think it was, or in Mexico, I forget which, wrote an article that says, is fibromyalgia really reflex sympathetic dystrophy? Yes! Fibromyalgia, in my world, is reflex sympathetic dystrophy. Now, people say, well, how can that be? Sometime go to a textbook and read a description of the symptoms of fibromyalgia. Forgetting about the tender point part, but read the rest of it. And then read a description about reflex sympathetic dystrophy and see if it doesn't throw up a thought in your mind, hey, these two sound an awful lot alike. Or more than that, because we're biased as medical professionals. Give it to somebody who's not a medical professional. Don't tell them which one's which, and ask them if they see. Fibromyalgia, in my world, is reflex sympathetic dystrophy. It is a subsect of reflex sympathetic dystrophy. Now, that doesn't mean that you can't treat the fibromyalgia, or whatever you want to call it, okay, as fibromyalgia, because it's just a low-level reflex sympathetic dystrophy. I talked earlier about the diabetic who's diet controlled and the diabetic who's getting 4 insulin shots a day. It's no different here. You're treating a low-level reflex sympathetic dystrophy that may just be confined to a specific body area. So I put this up here because really, this is not fibro. This is actually a reflex sympathetic dystrophy. You saw the rest of the study. I put this up there for that reason. But when you look at the back is relatively symmetrical, and she was going to have all this treatment for fibro, and then we changed the treatment and we treated her reflex sympathetic dystrophy, and she was early on, so it got better. There's a great crossover. People will walk in and say, what do you have for diagnosis? Well, I was diagnosed as having fibro. And I write it down, and I don't say anything. And then 6 months later, if they have reflex sympathetic dystrophy, I say, remember that fibro that you used to have? Well, it accelerated, and now we're going to call it something else. I kind of slide through it that way. I threw this in very quickly just to show you that thermal imaging will do breast disease. But the reason for putting this in is because this individual has reflex sympathetic dystrophy of the left brachial plexus, which caused the left breast to become much larger than the right breast, as you can see. And you've got all these blood vessels in here that don't belong. And this area right here, which is the normal side, doesn't match up. And if I had marked up the temperatures, you would see that the RSD came across the plexus into the anterior chest wall. And because of the reflex sympathetic dystrophy, caused the breast to accelerate in size. There's not many more of these, but I just want you to take a quick look. Back of the hands, in front of the hands in patients with reflex sympathetic, not so much the fingers here as the carve out. So for those of you who've never seen a thermogram, if I show you these pictures in a patient that you clinically suspect has reflex sympathetic dystrophy, this is pretty riveting. This is pretty interesting stuff, because not only A, does it help you with your diagnosis, and B, what a wonderful thing in a courtroom. You cannot imagine how much fun I have in a courtroom. Okay, I get up in front of a jury and I say, you know what, you want to believe my opponent, that's fine, and you don't want to believe me, that's fine, but tell me how they faked this if you don't believe this is real. Now, I will digress for a moment. Talking about me making friends, Allstate and State Farm, who are the 2 biggest insurance companies in America, decided in the 1980s that they weren't going to pay for thermography when I started in 1982. So I had a friend who was an attorney, and he was independently wealthy, and he said, let's just go sue him. So we sued Allstate, and we sued State Farm, and we sued the state of New Jersey. Will Rogers would have loved me.
And so we won. We had a 7-week trial. We brought people in from all over the country. We won, and we forced them to pay. And so they, of course, appealed it, and we won. And they, of course, appealed that. And we went to the Supreme Court of the state of New Jersey. Now, show of hands, how many people saw the Paul Newman movie called The Verdict? Okay, you know that story where he comes in at the end and he's this down on his luck lawyer who's an alcoholic and so on and so forth. Picture The Verdict with a guy who's not an alcoholic. I walk in a suit that I got at Men's Warehouse. Okay, my buddy walks in with this briefcase that was 25 years old, and here comes all state lawyers, okay, with their Zero Halliburton cases and their $5,000 suits, and here comes State Farm's lawyers with their $10,000 suits, and they're sitting over there, very pompous as it was, and the Supremes come in, and if you've never been to the Supreme Court, what a kick. I mean, it is just great to see them walking in their robes and all that kind of stuff. And they walk in, and they're there for like 5 minutes, and they say, you know, we've reviewed all this, and we're not really sure why we're here. You win. And they get up and left. And they voted 5-0, and so New Jersey is the only state in this country where thermography is mandated by Supreme Court verdict in motor vehicle related and simpler case because we sued them, and we won, which is more, so I have now friends in the insurance industry, they love me in New Jersey. But the point at hand is this is very riveting, and so what happens is that if you show this to somebody, whether it's an insurance company or a doctor or a lawyer, but mostly the patient, because the patient says, you know, Dr. X told me this, and Dr. Y told me this, and Dr. Z told me that, and you're telling me something, what do I believe? I said, you believe this. Somebody mistakenly called this a picture of pain. This is not a picture of pain. This is a picture of the mechanism that produces the pain. Now, the question was asked earlier, would I like thermography to be the gold? And that wasn't exactly that way. Would I like thermography to be the gold standard? Yeah. Everybody ought to have a thermal imaging camera in their backyard. Not literally, but you know what I mean. Okay? Because if we're going to diagnose RSD, let's do it early. Let's see where it's going to go. Let's treat it early, and let's do it this way because it doesn't cost that much to buy a camera. And you get trained and you learn, or you send the pictures electronically by email to somebody who reads them and sends them back to you. This is not rocket science. This is simple, straightforward stuff. And I am trying to get the spinal cord stimulator people to listen to me. I'll pass this along just for a moment. If you know about the insertion of the spinal cord stimulator, when you do a trial, they have a patient laying on a table and they put these leads in and they say, tell me when it feels okay. Tell me when the pain goes away. And so you have this person who's saying, yeah, it's better, because they really want it to work, so you don't really know if it's better or it's not better. And maybe it's not 50% better, and maybe it's just a little better, and then they put 50 pounds of tape on their back and send them home for 5 days. And so I talked to them, I said, what if I had a camera that operates in real time that this would get to look like this when you put the lead in the right place? Then you take the subjectivity of the patient out of it because it is in the right place and it is working. Geez, doesn't that make sense? 5 years I've been trying to sell this. I don't own a company that sells cameras. I'm not making any money from this. I'm just trying to explain to them that all these failures in stimulator insertions, some of them could be overcome by the fact that there's too much subjectivity. I can prove when it's in the right place. And anybody who's not out there saying, why the devil don't we have this going on? I can summarize it for you in one word: politics. This is the politics of American medicine. Just real quickly, this is a lateral right hip and a lateral left hip. You can't make it up. And the back of a foot. This lady does have a leg. This is not an amputee. This is the 2.7 degree temperature differential between her legs. So anyhow, my spiel, if you will, on thermography is that thermography really has to become the gold standard for the diagnosis of reflex sympathetic dystrophy because it is simply the best available diagnostic test. Go.
Can it be hot or cold?
Can be hot or cold. The question is, can it be hot or cold? And the answer is this. In the first 6 months following an injury, if there's an injury involved, I find it usually is warm. After 6 months, it almost invariably is cold. Every so often one drops through, but 99% of the time it's cold.
But it can vary, so it may not always be cold.
If a person has reflex sympathetic dystrophy, whether they are symptomatic at that moment or not, the thermogram will show this. Somebody could walk in and say, I'm having a great day, and the pictures are what they are. Yep. Yes, ma'am.
What about the last picture that you showed? Can it be peripheral vascular disease, something else?
The question was, can it be anything else? And the answer is, I've never known it to be anything else. Because remember now, I'm giving you sort of a summary of this. These people that come in have either been worked up or will be worked up to preclude, as in the last lady, vascular pathology,
I'm not taking anything at its face without more. I'm showing you what the end result is. So if a lady comes in with a leg that looks like that, yeah, she's going to have Doppler studies or whatever is necessary to do to determine that the arteries and the veins and everything in her leg is working. And having done that, remember, clinically, this lady has pulses.
Yeah, but it can resemble, or they are completely different or thermographic.
That's all sympathetic dysfunction in the leg that you saw.
Where I tried about 25 years ago and became popular, then it faded down. But we are criticized by a lot of false positive in this.
Okay.
So how can you...
I'm going to answer your question. Okay. This gentleman just said that 25 years ago the thermography was hot, and that's a bad choice of words, and now it's being criticized because of false positivity. Now, there's two answers to that question. In breast disease, and I will mention it because that's a lot of the criticism, something is not false positive in breast thermography until 10 years pass, and there's still nothing there because there's a 10-year window before a tumor will be perceptible that will show up on a mammogram. Neuromuscular-wise, I've done 6, 7, 8, 9,000 people thermographically. I have never, big words, never seen a false positive thermogram for reflex sympathetic dystrophy. Never. Okay? The false positivity comes from people who look at thermography, don't know what they're looking at, because they bought a camera, they had 2 days of training, and they think they're an expert, and they're calling it this, that, or the next thing. Also remember that this is picking up little things. I mean, you'll pick up small heat patterns, and if you start reporting every asymmetry, yeah, you're going to have false positive. If you're calling it reflex sympathetic dystrophy, you better recognize that there's nothing else that fits that diagnosis. And so when I write my reports say there is no other pathologic entity that this thermogram is explained by. This must be reflex sympathetic dystrophy. I've never had a false positive. Never had a false negative either, by the way, in RSD.
Are you doing already thermography for patients with fibromyalgia to try to relieve?
How to utilize it in fibro, is that the question?
If you are doing already something about trying to confirm what you said about fibromyalgia, and then we have different...
Well, the question about fibromyalgia is this. If you believe in fibromyalgia, and I'm not trying to tell you what to believe and what not to believe, if you believe in fibromyalgia, what a wonderful tool for identifying each and every one of the tender points in somebody's back, because it's a roadmap. It's a wonderful roadmap. You can adjust the temperature scale on this and make a roadmap out of this, and before you ever lay your hand on somebody, have a picture of where every one of those tender spots is. Okay? Can it differentiate between fibro and RSD? Yes, because remember, fibro mostly is confined to the spine. Mostly is confined to the spine. Reflex sympathetic dystrophy will get out of the spine and into the limbs. And so because we're taking pictures of the spine and the limbs, we're seeing an extension of the thermal asymmetry out beyond just the spine. I have an old Flexotherm equivalent. Flexotherm is liquid crystal. Anybody remembers mood rings, how they changed and all? Liquid crystal was the original thermographic stuff, and I still have this thing that I bought in 1982. And when I do an injection into a trigger point, I actually take and lay this liquid crystal thing right on their back. It lights up. Okay, I put my hand there and I put my finger there, I make a little X, I say, does that hurt? Yeah, and I don't ever have to wonder where a trigger point is because I find every one of them electronically or by contact and just go in and shoot them. So my success rate, I'm not any better than anybody else, I don't do this full time. I got a picture. It's telling me right where to go. What could be any easier than that? Okay. No? Yes, I thought you.
How about the Raynaud's phenomenon? Does it show?
Question about Raynaud's phenomenon. The thing about Raynaud's phenomenon is something that you can see clinically. Okay? So we're now mixing the clinical with the other. Okay? If I have somebody that may have Raynaud's, and I have a lot of people who have been diagnosed with Raynaud's and don't really have, but if somebody has Raynaud's, then they're going to be in a room. Our temperature grades, the room is 70 degrees. If I look at that patient and that patient's feet don't look the same because I think it may be a Raynaud's, I'm not going to do the study because I have to take the variables out. Okay. So, we talked about this earlier, and I'm not going to repeat what I already said. So let's talk about ketamine. Now, let me do it this way. Ketamine started in 1963 because they were looking for what they called the ideal anesthetic. And that should say name. The second line, it shouldn't say the main, it should say name. I put that in, and they proofread my slides, and we're all dyslexic. But anyhow, that's where ketamine came from. Now, in the real world, here's what happened with ketamine. Ketamine was released as an anesthetic, and it worked very, very well. And so they used it, and then two things happened. Thing number one was that, as is always the case in medicine, they found a better one. And sometimes that translates into less side effects, and sometimes that translates into it costs more money, but they found better anesthetics. The second thing that happened was they found that patients who were getting ketamine for long procedures, like bypasses and stuff like that, were waking up sort of psychotic. And it went away, but they began to have reservations about using ketamine in those instances. And so it was replaced with other drugs, and it's not my place here today to tell you what drugs replaced it, but rather to tell you that ketamine still exists predominantly in two places: in dentists' offices and in emergency rooms, where they use ketamine for short-acting anesthetic effects in kids where they have burns and they have to change the dressings. So ketamine is by no means gone. What happened was that in 1997, some researchers in the country of Australia were playing around with drugs, and they found that they had given ketamine anesthetically to patients with reflex sympathetic dystrophy, and lo and behold, when they woke up from their anesthetic procedures, their RSD pain was less. And so they decided they were going to study it, and the way they studied it was they used it in subanesthetic dosages, and they did this for a couple of years and wrote a paper in 1997, which was the first paper, talking about ketamine in subanesthetic doses for reflex sympathetic dystrophy. The lead researcher in that group, who was an American, actually came back to a place called Pace, I never remember which one it is, in Arizona, and began doing ketamine treatments one a month in a holistic health hospital in that town. But he had no funding, and he really had no desire to be the center of a new wave movement, so he brought it east to Bob Schwartzman at Hahnemann, who is a guy that's seen almost 5,000 patients with this disease and acknowledged, if not as the nation's foremost expert in the disease, maybe the world's foremost expert in reflex sympathetic dystrophy. And he, and shortly thereafter I, began talking about using ketamine in anesthetic and subanesthetic form. And from that, in the early part of this 21st century, we began using ketamine. Now, for someone who asked me the question about Germany, what happened was that we recognized that ketamine worked very, very well in a subanesthetic form. And I'll explain to you what I mean by that in a minute. We also found out that it wasn't enough. It was kind of, in some patients, like trying to shoot an elephant with a handgun, and it just wasn't going to work. And so Dr. Schwartzman contracted with some people in Germany to do anesthetic doses of ketamine. Anesthetic doses of ketamine meant that people would get on an airplane, fly to Germany, go through a rigorous workup, and then go to sleep and be put into a drug-induced coma, where they would remain for 5 to 6 days getting huge doses of ketamine, which would otherwise have made them psychotic. And when they woke up, they would stay there for 3 or 4 more days until some of the cobwebs cleared, and then they would come home. And we found that people coming back were vastly, vastly better. And these were the worst cases of RSD that either one of us had seen. These people were cured, quote unquote. They were 80, 90% better, and they were functional. And so we thought we had hit on something, and we then found out, much like the Robert De Niro movie, which I can't remember the name of, where the disease came back, that if we didn't do something, that they all got bad again after 6 months. 1 or 2 of them stayed good, and after a while, people all started to get bad again. So we came to the recollection that what we needed to do is we needed to maintain ketamine in their system, so we started doing boostering, where people would get sub-anesthetic doses in this country to booster what they had gotten in Germany, from which grew the sub-anesthetic movement of ketamine in this country, which I'm going to talk to you about in a minute. The problem occurred when a patient a year and a half ago in Germany came out of her coma better from a reflex sympathetic dystrophy and racked with MRSA, which caused neurologic effects, and the people in Germany really had no idea what to do with the patient, quite frankly, and they really do a very nice job in Germany in a lot of ways. And so this lady was getting worse, and they thought she was going to die. And the local Philadelphia newspaper had a plea to get this woman home, and somebody came forward with a whole bunch of money, and they airlifted her back from Germany to Hahnemann, where she was treated, and she's still alive and recovering, albeit slowly, but not from her reflex sympathetic dystrophy, but from the neurologic side effects of her MRSA infection. Germany said, that's it, we're done. No more. One was enough. We're not doing this again. And they opened up another center in Monterrey, Mexico, that is being run jointly by an individual in Tampa, Florida, and one in Monterrey, Mexico, that is doing this in an anesthetic fashion. And they've done 15 or 20 folks, and some of them are better and some of them are not better. The anesthetic doses of ketamine are really limited to those people who are just so bad that nothing else is working. They did have one death in Mexico, to be fair, of a young girl in her 20s who had gone to Germany, gotten better, relapsed, had congenital heart disease, which is a no-no when you're doing ketamine, and opted to take the treatment because she had no life and said she'd rather be dead than to have to live this way. Woke up from her drug-induced coma, pain-free, and 2 days later went into right heart failure, from which they could not get her out of, and she subsequently succumbed to it. But they're still doing anesthetic doses of ketamine in Monterey. And so, talking about the sub-anesthetic, which is what we're going to do right now, its action is on the NMDA receptor, and sub-anesthetically, as I said, in burn victims and in non-malignant pain and in some cancer pain, ketamine still exists. So the anesthetic is being done in Monterey. The sub-anesthetic is now up to about 30 sites in America. When we started in 2004, it was Dr. Schwartzman in Philadelphia and myself in New Jersey, from which grew and multiplied, and now there's at least 30. There may be more spread out all across the country of people doing ketamine. Now, some people are doing ketamine the way we propose to do it, and some people have taken it upon themselves to change the protocol and do it in different ways. We have found that ketamine is best given over a long haul, meaning that we give people ketamine over a period of time. There are some individuals who think you just give them a whole lot in one shot and that's going to make a difference, and it's something with which I disagree. But the procedures have, the outpatient protocols that everybody has tried and failed, that they have the diagnosis of RSD, that they have been cleared cardiac and psychologically. Now, before I go on, let me tell you the psychological clearance does not include a diagnosis of depression. People who are depressed because they have chronic pain and have no life are not excluded from the study. People who are manic depressives are, because this is a psychotropic drug, ketamine, and we don't like surprises. So they all have psychological and cardiac clearances, and then the way I do this is I do 5 consecutive days in accelerating dosages in my office, which is set up like a mini ICU. I have a 1-to-5 ratio to an ICU nurse, and we have cardiac monitoring and pulse oximetry and so on and so forth. And we bring up to 5 people in, and we plug them into IVs, and we give them ketamine in saline with adjunctive drugs. Now, the adjunctive drug is dependent upon their need. If they get a headache, we treat the headache. If they get nauseous, we treat the nausea. If they get anxious, we treat the anxiety. So whatever they need, we give them in addition to this. And we usually start them at 60 milligrams of ketamine over 4 hours, which really has no effect on anybody. And we accelerate the dose up to a maximum of 250 milligrams over 4 hours. And it really depends upon how people respond. Most people start getting a positive response at day 3. By day 5, they are significantly better, and by 10, substantially better. And so then we go into a step-down protocol. Now, Dr. Schwartzman and I have different protocols. Mine is that I do people 2 days a week for a month after that, and then 1 day a week for a month after that, and every other week for a month after that. And some people go to 2 a month, 1 a month, every other month, every third month. It really depends upon the individual. We have found in the people that we've done, and I personally in the office have done about 80 folks, we have found in the 80 or so folks that I've done that about 80% of these people are better. Now, how do I define better? Better means that they are on less medicine and or they have more quality of life. Some of it is subjective. I mean, somebody comes in and tells me that they're out front playing basketball with the kids and when I met them they were in a wheelchair. I don't need them to tell me they're better. Okay? Most of these people we have been able to reduce the medication. And most of these people, when you talk to them, will tell you that they would never give it up for anything because it has pretty much saved them. And so they need an access line, and as I said, monitoring and pain assessment and direct observation, and we give them midazolam and benzos, and not everybody gets this, but this is what we give them, what they need.
And the number 300 at the top is his and mine, his being Dr. Schwartzen and mine, in terms of the 85% improvement. Now, I need to tell you some things before we talk about, actually let me do this. They wanted me to do slides about case histories. Actually, they took them out, okay, so forget about that, I apologize for that. There were two more slides that I had there, and well, we'll leave that because I don't really need it. There were two more slides that I had there that were taken from the RSD website of someone with a swollen, dystonic hand. And my thought was that I would put it up there to show you what I almost never see. Let me talk to you just for a moment about the ketamine. I've had people that we stopped in ketamine because I couldn't hold the ketamine. What I mean by that is they get better as long as I would give it to them every day. But once I stretched it out to once a week, their symptoms came back. That to me is a failure. I had one woman whose husband was so possessive of her that he convinced her that she was going to have all these side effects that don't come from the drug that she managed to have psychologically, and we aborted that. I've had a couple of people who we've stopped for insurance-related reasons. But by and large, most of the people that we have started, we have done very well in. And I will give you just two off the top of my head. I had a woman who came into my office in a wheelchair and was unable to stand without assistance and could take no more than 1 or 2 steps. In addition to that, she was throwing up, or at least gagging, somewhere between 25 and 40 times a day, which is a little disconcerting. And she is now a year into the ketamine treatment. Not only is the wheelchair gone, and the gagging and the nausea and the vomiting gone, but she went back to work. She carries a cane in her trunk just in case, which she doesn't use, and she works 3 days a week off-site and 2 days a week at home. And aside from the fact that we've not been able to cure her neurogenic bladder, she takes no medicine. Interestingly enough, the insurance industry decided that she didn't need the ketamine, and it wound up being a legal issue that just last week the powers that be decided that they kind of agreed that she really did need the ketamine when she walked in there without a cane, having read the description of the other. The other is an 18-year-old girl who I met when she was 17, and I made her wait till she was 18 to start her. Very overweight and deconditioned. And this young girl was wheelchair bound, and this girl couldn't even stand up. I mean, in the sense that her father and I would lift her, and I said, just stand here. You don't have to walk, just stand here. And she would fall back down in the wheelchair. She came in to see me in late February, early March, complaining of back pain from shoveling snow. I just looked at her. I said, I don't hear all that well sometimes, and I said, I must have misheard you, and she said no, and she was out shoveling snow and overdid it, and her back hurt. She walks in. She's now very upset because she can't go out with her friends and do the things she wants to do because she's not quite at that point. There is no wheelchair, there is no cane, there is no walker. You see stuff like this, and even the toughest of us are sort of brought to almost tears because it really is the closest thing that you see to a miracle. Now, I'm not calling it that, and it's not my purpose here. And for everyone like this, I tell you, there are people who have not done quite all that well. But it is, in my estimation, at least at this juncture, the best treatment that we have. Now, I'm going to put a footnote to this, which is not in the literature, and this is my own personal stuff, and because they let me stand up here, I'm going to give you an opinion. I don't think that ketamine is the ultimate answer. I think that ketamine is a means to an end. I think that if we take these people that are really, really bad, and we can get them into the arena of fixability, which is a term that I made up, there are other things that will make these people yet better. If you take somebody like the two that I just described and try and make them better with other means, it's not going to work. But if you get them to the point that they can stand up and they can walk and they can go and they can do, you now have them in a manageability place. And the manageability place for me ultimately is to put them on a rigorous diet, to put them on a rigorous exercise regimen tailored to their specific needs, to put them on whatever is necessary from vitamin and supplement that is appropriate for them, to have them seek psychological counseling to the point that they are driven to positivity and not negativity,
and to then begin to withdraw the ketamine, because we will then have people in an all-natural fashion working to their own benefit. Because see, right now, I'm making these people better. They show up, but I'm making them better. I want them to make them better. I want, you know, I use this as an example. It's kind of silly, but it proves a point. I tell my patients that the Munchkins put Dorothy on the yellow brick road. She walked the road. They put her there, but it was up to her to get to Oz. And I don't want to walk for these people. I want them to walk the road. And I think we as clinicians tend to forget sometimes that the patients have a responsibility, and it's a very big responsibility, that they have to be a part of their cure. The families do, the patients do, they all do. And it's all about positivity, and I think people forget that when they come in. We've recently started a support group, and the mandate of the support group is that if you say something negative, you have to leave the room. We started with just a few people. I suspect that it's going to grow rather rapidly, because I think people want this. And people police themselves. You know, somebody asked a question about the internet earlier. There are websites where everybody's in the negative, and there are websites where people are not. And I think when you get to the positive, you get into there. I want to just take about 5 minutes for those of you here, just to run a couple of things by you, more not so much in the sense of case history, but just a couple of examples of things that I've seen that may be of some benefit to you. I had a woman who worked in one of the resort casinos. I said, I'm in New Jersey, and in those days they used to have money carts, and the money carts had money, coin, and this one money cart got loose from the guy that was pushing it. It went down the ramp, and it hit her in the side of her thigh, and she wound up with a contact nerve injury, from which she developed reflex sympathetic dystrophy, which then migrated from her leg to her arm. And we were fortunate enough to get her leg better by hospital-based epidural, and we were fortunate enough to get her arm better to the point that she was somewhat functional. And about a year and a half after I started to treat her, she asked me if I would mind seeing her sister, who was a police officer. And when her sister walked in to see me, and they weren't twins, or they were sisters, independent of this woman, she had reflex sympathetic dystrophy in the exact 2 same sites from a motor vehicle accident in the course of her employment. Now, she wasn't making it up. We had pictures and treatments and physical examination, but what's the likelihood of it happening in exactly the same spot in the thigh and into the arm? And so when I talked about genetic predisposition, it's just something to think about. The second thing, which I never talked about and really is very important, is the role of pregnancy in RSD. Now, this has got to sound like a really bizarre comment, the role of pregnancy. Pregnancy makes RSD better. If you want to know why, I'll go back to my I don't know, but pregnancy makes RSD better. I have a young girl who at the age of 18 was in the hospital with some regularity, and in this regularity, she was getting morphine infusions, and I will get back to the question, which I forgot, morphine infusions and all kinds of drugs, and she unintentionally, I will say, got pregnant. And in her 3rd month of pregnancy, and it's usually the 6th, but in the 3rd month of pregnancy, she was symptom-free. She had her baby, had no recurrence of symptoms, and she went 2.5 years symptom-free. She had no symptoms. I mean, she was just take care of the baby, living her life. And the symptoms started to come back, and she got pregnant again. Now, I don't know to this day whether one thing had anything to do with the other. She swears it didn't, but... And so in the 3rd month of her 2nd pregnancy, she got symptom-free, and the symptoms never came back. And then she got pregnant a 3rd time, not because she had any symptoms, but I have now seen 12 to 14 individuals with reflex sympathetic dystrophy, and every single one of them, at some point in the 3rd trimester of their pregnancy, begins to have a reduction of their symptom complex that lasts beyond delivery if they breastfeed. So I know that there is a hormonal basis here somewhere, and we're working on it. The problem is, I'm afraid that the hormonal stuff, and I am by no stretch of the imagination a hormonal expert, may have the side effects associated with late-term pregnancy, and that's not going to do us any good. But it's interesting to know. The gentleman here had asked me a question about opioids, and I thought it was here, and I apologize, so let me address the question. Much to my dismay, I write a lot of opioid prescriptions. I don't like it, but I do. I try to stay to the four different kinds of pain, but That notwithstanding, I write prescriptions for opioids. I write prescriptions for methadone when I can because it works very, very well and it has a long enough duration of action that I can manage it and control it. Morphine in short and long-acting form, fentanyl in patch and pop form, oxycodone in all kinds of forms. Everything has their place. What works interestingly is Suboxone, buprenorphine, which I found out yesterday from somebody across the hall, is being released in January in patch form with an indication for pain. Currently, Suboxone is released only for detoxification of drug addicts, although we use it for pain. And you need an X number. You don't need a DA number. You need a special number that begins with an X to write for that drug. You will not do that. This is coming out as a class 3 drug. This is not an advertisement. It's just a statement of fact. And it's going to be a 7-day patch using buprenorphine for pain. They got the indication. The OxyContin people did, so I guess they're trying to corner the pain market. You give people what they need. The problem is that when you give it to them, people need more and need more and need more, and you have to be really, really careful not to fall into that crater of feeling sorry for somebody and giving them more. I used to do that because I'm human. I learned my lesson in the following instance. I had a woman that took 400 milligrams of fentanyl at the same time. She had 4 100 patches lined up on her arm at any given time. And I tried for the longest time to get her off of it, and I finally was able to coerce her into doing that. And over a period of almost a year, I took her from 400 to 350 with no change, meaning she had the same amount of pain relief at 350 as she did at 4. When I got her to 300, it was the same as 400. When I got her to 250, it was the same as 400. When I got her to 200, it was the same as 400. When I got her to 175, she came back to the office the next day screaming at me. So I found her threshold by accident, and I learned my lesson. And what I really, really try to do is get away from the opioids as much as I can. And I have a lever. If I put somebody in the ketamine infusion program, it is with the understanding that if the ketamine helps you, the opioids begin to go away. And people will make that trade if they really are serious about getting better. I can't tell you that any one is better than any other one. You know, I don't have an answer to that question. We use them all, but I try to use it for the pain of RSD, and I try and mix the other drugs in to minimize the use of opioids. Yes? Let me come down because I hear better close up.
For pain also in this
Say it again.
condition? Yeah, ketamine,
Right.
inhaled.
The ketamine, and I'll make this, I'll end with this because everybody wants to go eat and do things. Ketamine in its oral form, ketamine in its inhalation form, ketamine in its topical form have really not shown any great hope and promise for me other than maintaining a blood level in people who are getting infusions and needed to get them through to the next infusion. Let me answer the questions after because I know some people want to go, and so I'll stay as long as necessary and talk to everybody. I thank all of you for coming. Anybody wants to go have lunch, please do that.